Hello, my name is John Hunninghake. I'm one of the pulmonary and critical care staff there at BAMC. First off, I want to welcome you all to San Antonio, and I want to welcome you to the first ever virtual Fundamental Critical Care Support, or FCCS course. We've been doing this course, or I say this course has been done almost for 10 years now, during June orientation for new interns. And this is the first time that we've ever had to do it online. Normally it is a 3-day course, 2 to 3 day course in person with a combination of lectures and simulations or skill stations with simulations that's conducted there at BAMC. First off, I want to give a shout out to my co-director, Dr. Whitney Warren. She's another pulmonary and critical care staff there at BAMC. She really has stepped up. As I was deployed last minute in April as part of the military's COVID response, I do receive a lot of help for some of the duties, and so she was very willing and able to help out, and so I do want to kind of give her that shout and the appreciation of everything that she's done. I also want to thank ahead of time all the faculty instructors that are going to be helping teach all these lectures online. It was kind of a big pivot in terms of how we normally do it, where they're able to do it in person and have that audience interaction. So I appreciate all the time that they're dedicating to recording these lectures online or at their computers so that you all can watch them. And I do want to address the fact that the skill stations and the scenarios that go along with them will be conducted at a later date. Hopefully it'll be around the time that I'm getting back. If not, if that doesn't happen sooner rather than later, and that will be part of the formal completion to allow you all to get certification for the course. So to kind of go through the course, I do want to highlight some important points. The course really is targeted for non-intensivists and to teach those fundamental principles of ICU medicine. We really are trying to help refresh all of you on what you've learned through medical school, help kind of get you back into the clinical thinking, and normally this course provides a nice break from all the administrative aspects of orientation. So I apologize that if this is seen as one more thing to do, another thing to listen to online and not have personal interaction. I apologize about that, but I hope that through these lectures and eventually the skill stations, you will learn some important skills that will help you when you're in the ICU during your intern year and beyond. Really what we're focusing on is trying to provide that foundation, that background to the important principles of ICU medicine so that you feel qualified and capable to manage these patients in kind of that initial setting, to help define patients that are sick versus not sick, and to help know what the initial management strategies should be so that we are able to help the patient out. What we want to avoid is any delay in patient care that might cause them to have some type of morbidity or hopefully not mortality, or to be overreactive to the smallest changes in patients so that we're not able to effectively do patient care or effectively manage patients and know when we have to allow them to, although they might look a little sick or things might not seem right, we have a good foundation for how we're managing them, and we know the plan A, B, and C, then we can help manage expectations in kind of crisis scenarios and help to remain calm and confident in what we're doing. So this course is not meant to be a substitute to consult intensivists or to transfer a patient to a higher level of care. So trying to be the big dog and take care of really sick patients on the floor might not be the answer all the time, if any of the time. Knowing kind of what resources you have there at the hospital or other hospitals where you might work, and knowing when it's appropriate to ask for help are extremely important examples of what you can learn from this course. Again, we want to teach you how to manage these patients as best you can, but to know when it becomes kind of outside your capabilities or the nurse's capabilities of where you're treating the patient. So it is not a failure to have to transfer a patient to a higher level of care if it comes down to that, if that's truly indicated. We're asking for help to receive reassurance that you're doing the right stuff and that they can continue to be treated where they're at. So I really encourage you to remember during your first year, you don't have to prove yourself. What you should do is work hard to take care of the patient and do what's right for the patient. Ultimately, this course is not meant to try and teach you the long-term care of ICU patients. Albeit, I do want to highlight the fact that the military is unique in a lot of different ways, but especially for physicians in your all's places, you might be deployed in an ICU and expected to work at the level of an ICU physician. I highlight that because really we want to emphasize that the knowledge you gain, hopefully through this course and through your experiences in the ICU, is not stuff that you might say, oh, I don't need to remember this because I'll never have to do it. This might be very relevant to what you're doing in the future as a military physician if you get deployed to an ICU, or if you get deployed as a surgeon who's taking care of trauma patients. Being able to know some of these critical care principles will serve you very well. You will get refresher courses in the future, but this will help set that foundation so that when you go into the ICU, you're mentally ready to say, I'm here to learn as much as I can. Because albeit, if you're in a field that you don't think critical care is an important part of it, I want to be upfront and outright that you're wrong, because we're all going to see critical care at some point in this stage. Even dermatologists, not to call you out, dermatologists, but it is something that dermatologists get deployed as intensivists in the military. And so I say that kind of laughing because I want you all to enjoy the course, but I also give the little dose of seriousness that I ask you to take it seriously, to try and learn as much as you can so that it'll help you in the future. So what are the requirements for the course? These are just some housekeeping items. We're not tracking attendance. We're not going to track all the lectures you watch. The things that we ask you to do is kind of to be on your Scout's honor, to listen and watch all the lectures. Hopefully this will kind of give you a reprieve from other aspects of quarantine life. Usually the live audience participation is what instructors feed off of. So if there are awkward moments when we're talking to ourselves in a computer screen, I apologize for myself and others. But I ask that you do your best to try and act like you're there, to try and act like you would with your responses, and at least think out loud as to what when we're asking questions, and these lectures are geared to us asking questions to an audience, that you do your best to answer them. There is an accompanying textbook, but it is not a requirement that you read it all, or if any. We ask that you use it as a reference. The textbooks and the course cost money. Graduate Medical Education, or GME, which is the organization that oversees all the residency and fellowship programs at the hospital, paid for it for all of you all. So we ask that you take it seriously, that you do your best to utilize the book and have it as a reference and resource. I will give you the heads up that it is about 5 years old in terms of it is the 6th edition. That was, as you can see by the copyright at the bottom of the screen, was done in 2016. There's a 7th edition that's coming out this year, so unfortunately we just missed out for this course, and I apologize about that. But all the instructors who will be giving the lectures have been asked to provide any and all updates. There are some slides that might have some elements that are old, and because of the FCCS copyright, we can't change the slides, so I apologize ahead of time about that too. But that being said, listening is going to be more important than just reviewing the slides, because that will help put it all together. The lectures are meant to be about 25 to maybe 30 minutes. Some will probably run long. Usually every year we're having to tell the lecturers we're kind of having to give them the 5-minute warning when they're halfway through their slides. I say that jokingly, but in all honesty, there are some lectures that will go a little bit longer than others because of the density of information that is attempted to be included in the slides, which as part of the 7th edition that unfortunately we won't be able to see, I can assure you has been corrected. There is a pre-test that I'll go over here shortly, so once I get to the next slide and I'm there, I'll ask you to pause it because then I'll actually start going through all the pre-test answers. There are 20 questions, and I ask that you complete the test either by printing it out and circling the answers that you marked, or to go to a PDF version and mark them on the PDF and save it. I will ask that you keep the pre-test with your answers, so that I can receive it when we do the skill stations portion in the future. There also will be a post-test that will be completed at the end of all the lectures. I will go over it with you all. It is not technically for a grade, but again, it's the pre-test is meant to establish your baseline knowledge, and the post-test is meant to establish kind of what you learned from the course. And so that will be required, kind of a marked test will be required to be given to myself in order to receive credit for the course too. You will receive a certification saying that you completed the course after you have come to the skill station sessions, which again will be scheduled at a later date, most likely in months to come, and more details will come about that if you haven't already received them. Finally, there will be a course evaluation where you can provide feedback. Again, I ask you to provide all honest feedback. We're very open to any and all, knowing that this is our first kind of virtual course that's been broken down between these online lectures and then eventually the kind of in-person skill stations and scenarios that will occur there in the simulation center. I ask you to be honest on kind of how it's going. So this is something that I'll remind you to fill out after completion of the skill stations in the future, which again, you will receive more information about how to schedule. So I promise that no one will be left out from all this, that you will all receive information about how to get that complete. So with the actual content of this course, we try and tailor it to the participants as much as possible, albeit this being virtual, that is one of the limitations. The topics that we're going to talk about, we're going to try and emphasize the ones that have very important and relevant clinical issues. Ultimately, that last bullet point, emphasizes that we ask you all to increase your knowledge as much as possible with the book and other resources. There are many resources out there. A book that I cannot formally endorse, but I can say that I recommend to most people who are asking to learn more about ICU medicine is called the ICU book by Dr. Marino. That is one that, again, provides a lot of good baseline information, knowledge, and explanations about common critical care topics. All right, so without further ado, if you have not completed the pretest, I ask you to pause it now. For those of you who have completed the pretest, I will start going through it. It's 20 questions, and what I will do is just quickly highlight what the question is asking, give you the correct answer, and then any pearls of wisdom that I can provide with it. So number one, which of the following parameters may be a late sign of cardiovascular disturbance, signaling failure of the compensatory mechanisms? So the correct answer is C, hypotension. And this is something that emphasizes how you must respect hypotension as a very important marker of a patient who's critically ill, albeit it can occur a little bit later in the course. So be looking for those other markers that might indicate the patient's not doing well. One important one being tachypnea. Number two, investigative tests should be based on the patient's history and physical examination, as well as on previous tests. Which of the following is one of the most important indicators of critical illness? So the correct answer is B, Bravo, metabolic acidosis. As you'll learn about in one of the lectures, a patient's acid base status and disorders associated with it are very important information in critically ill patients. So number three, so what I will do is I'm going to start with some of the longer questions. I'll read the last kind of question of what it's looking for first. So for number three, which of the following modifications of the manual assisted ventilation technique is appropriate? So you can look at those. Those are different aspects of how you can help with bag valve mask or how you can adjust the patient. And you have a 22-year-old man brought to the ER, fell from a horse, awaiting transfer, chest contusion, non-displaced femur fracture. So he's in spinal motion restriction with a cervical collar on long backboard. So indicating there's a potential spinal injury. Then he has worsening respiratory distress and hypoxemia. So putting together that he could have some type of a C-spine injury, high C-spine injury, indicating that he has diaphragmatic, his diaphragm he might have phrenic nerve injury and diaphragmatic insufficiency. He requires endotracheal intubation. So which technique is appropriate? Is C, Charlie, using a jaw thrust technique in place of neck extension. And this is something that you'll learn more about in the airway lecture, kind of talking about how you can optimize a patient's airway and how that has to be modified according to the patient's clinical presentation. For number 4, which of the following anatomic features is most likely to contribute to difficulty in maintaining a patent airway in a supine patient? The correct answer is B, Bravo, posteriorly displaced tongue. This has in the past been viewed as a tricky question, but it does highlight the importance of why certain airway adjuncts are important in terms of trying to help open up the airway as much as possible. Number 5, an elderly patient is on the medical ward for respiratory distress. Which of the following is correct regarding airway assessment? So this is D, delta. Complete airway obstruction is likely when chest retraction and movement is present, but there are no breath sounds. So again, historically, this has not been everyone's favorite question, but it does deal with some airway anatomy and physiology that you'll learn more about. All right, so in number 6, kind of reading the last portion of the question first, which of the following initial interventions is most appropriate for this patient? So you have an 82-year-old, chest pain, evaluating the ED, alert and oriented. He's placed on the cardiac monitor, a normal sinus that he develops with ST segment elevations. So he's seen to have ST segment elevations. Then he becomes responsive and develops VFib. So what is one of the initial interventions that's most appropriate? So the correct answer is C, Charlie. Start cardiopulmonary resuscitation, or CPR, while preparing to defibrillate. So this just highlights the importance of immediate CPR in these patients. He is 82, so there is a question about knowing what his code status is. And this is a really important reminder that you should always do your best whenever you're first assessing a patient to assess code status, to address it by talking with them or to kind of get them thinking about it. The answer, they might not always know the answer, they might be confused by kind of the discussion of it, but I want to highlight this as an extremely important part. We aren't going to be doing the CPR lecture, the ACLS review, but you should get ACLS qualified if you haven't already during orientation or soon thereafter. Number 7, which of the following is the purpose of cardiopulmonary resuscitation? So this is D as in Delta, and it's to reverse sudden unexpected death from a reversible disease process or iatrogenic complications. So hopefully this is an obvious answer to you all, but I do kiddingly encourage you not to be that iatrogenic cause. So realize sometimes that things that we do can harm patients. So be thoughtful in everything that you're doing for patients and in the context that you're doing them. So number 8, I'm kind of going to the last segment of the question. Which of the following pharmacologic treatments should be initiated? So you have a 75-year-old, long history of smoking, chronic lung disease, treatment noncompliance, brought to the ED. Sounds familiar. He has progressive dyspnea. He's awake, alert, moderate distress, accessory muscles, respiratory rate of 30. There are audible expiratory wheezes. So as I'll talk about in the assessment lecture, is this patient sick or not sick? So he's sick. Likely diagnosis, COPD exacerbation. The correct answer is going to be A, alpha, inhaled beta-2 agonists. Breathing treatments are really the best available answer in these different questions. And you will learn more about kind of different patient presentations in some of the lectures and the specialized populations and a refresher on how to treat them and what the mainstays of treatment are. So number 9, long question. Which of the following is the most appropriate next step in this patient's management? Okay, 65-year-old, pulmonary edema, heart failure, alert, tachypneic at 30, SpO2 of 88, a little bit of JVP in inspiratory crackles. She's got looks like a kind of a respiratory acidosis and hypoxemia with that blood gas. She gets diuresis, antihypertensive. She's placed on bi-level, which is BiPAP. She has an inspiratory pressure of 12, expiratory pressure of 8, so 12 over 8. Delivered via full face mask with an FiO2 of 0.5, so it's 50%. So 2 hours later, after she has this, the nurse calls you and says to reassess the patient. The patient's now agitated and not following commands. SpO2 is somehow 85%, and your repeat ABG is worse. So worse in terms of the respiratory acidosis, and the PaO2 somehow 65 with the SpO2 of 85. So what is the most appropriate next step in this patient's management? So the correct answer, well, I should say before we do that, is this patient sick or not sick? Sick, likely due to acute decompensated heart failure and a worsening respiratory acidosis. There could be a little bit of pneumonia that precipitated this too, hard to say. She did receive a trial of non-invasive positive pressure ventilation by BiPAP for 2 hours. And did she improve? No, she didn't. She's getting a little bit worse. She's getting more agitated, so she's getting a little bit more altered. So ultimately, you can say and declare that she's failed non-invasive at this point. And so your best answer is going to be Charlie, intubate and initiate invasive ventilation for this patient. If she were not doing that bad, if she was still alert, you could sometimes argue, and in real practice, that we might continue non-invasive for longer than an hour or two. Sometimes patients will be on as long as 24 hours, but we do want to see improvement. So in this question specifically, she was not doing better, she was getting worse, so she did require intubation. Number 10, which of the following is the most appropriate initial ventilator mode for this patient? An 18-year-old, acute asthma attack, sedated and paralyzed. ABG is a severe respiratory acidosis, a pH of 7.08, PCO2 of 75, PaO2 of 63, and FiO2 of 40%. There are high-pitched wheezes. So, most appropriate ventilator mode is going to be C, Charlie, assist control of volume ventilation. So generally speaking, volume control is preferred in exacerbations of obstructive lung disease like asthma and COPD due to this risk of hyperinflation and breath stacking that can occur with pressure control modes. So that's something you'll learn about more in the mechanical ventilation lecture. I do want to highlight that answer A, CPAP, is not a ventilator mode, albeit you'll see it on ventilators. All right, number 11. Let's see. So apart from antibiotics and resuscitation for sepsis, which of the following is the next best step for management of his respiratory failure? So, 56-year-old, 3 days of fever, chills, cough, sputum, only takes amlodipine for hypertension. He is tachycardic to 130, tachypneic to 32, hypotensive 80/40, febrile to 38.8 Celsius, and he's requiring 6 liters of oxygen by nasal cannula to keep his O2 sats at 92%. He's got crackles, bronchial breath sounds in both lower lobes, multilobar consolidations, so likely pneumonia. He's awake and alert. He appears distressed and marked accessory muscle use. So, is this patient sick or not sick? He's definitely sick. What's the best answer at this point? So this one, again, kind of going through all the answers. A, could you do a trial of non-invasive by face mask? Possibly. He is hypotensive, and that's one thing that might push you one way or the other. Could you do C, where you do high flow oxygen therapy? Possibly. They don't give you a blood gas to suggest that this is an issue with hypercapnia, hypercapnia. So, and he is hypoxic, so you might be able to try that. That might help some of his hemodynamics. Could you try non-invasive mechanical ventilation by helmet? Potentially. This is something that's kind of been interesting and evaluated in ARDS for patients. And the FDA hasn't formally approved it, nor are helmets really available at any hospitals. So ultimately, you've got this 56-year-old with multilobar pneumonia who is in septic shock. At this point, doesn't talk about, though, that has he gotten any IV fluids or what treatment he's gotten for his hypotension, but what they're pushing you towards is that he's pretty sick, and so he should be intubated. So the correct answer is B, Bravo, where he gets intubated and initiation of invasive mechanical ventilation. Albeit this could be up for debate, and he doesn't supply all the necessary information to kind of push you maybe one way or the other as to where he's going. Albeit, again, he's, there are some aspects to his care that, depending on how he was doing, you could do potentially a trial of non-invasive on him, of how he kind of clinically looks at that point. All right, and how he does. So number 12, which of the following is a clinical indicator that this patient would benefit from further fluid resuscitation? So you've got a 56-year-old, he's in the ICU for pneumonia, he's intubated, you've got his vent settings there, his blood pressure is 88/46, so he is doesn't give you a map, but I would imagine it's below 65. SpO2 is 97. He has a central line and an A line, and he's been started on broad spectrum antibiotics. So, in terms of how to decide fluid status, this is one of the eternal debates that rages on still in critical care and elsewhere. And as you'll learn in the lectures, there are many different ways to assess volume status, and everyone kind of does it a little bit differently. That being said, the best answer here is going to be B, Bravo, the passive leg raise, resulting in at least 20% increase in systolic blood pressure. There was a recent randomized controlled trial that came out, I believe, March-ish, sometime in the spring, regarding using the passive leg raise in the assessment of stroke volume after giving volume and assessing patients for volume responsiveness. So it's a very important topic, and the correct answer is going to be doing that passive leg raise. So I highly encourage you to learn more about it through the lectures. All right, so some of these next ones are kind of long stems, so I'm going to try and just get right to the learning point. So number 13, which of the following findings has been shown to correlate with the worst prognosis in the patient with this clinical picture? Ultimately, the answer is C, Charlie, elevated serum lactic acid. So lactate's imperfect and nonspecific, but can be a very helpful lab marker that, as you will see in one of the lectures, is directly correlated with mortality risk. Number 14, which of the following vasoactive drugs is most appropriate to administer next? So in the question stem, you have a 65-year-old with abdominal sepsis. And so the correct answer is going to be C, Charlie, norepinephrine, also known as Levophed. So this is a patient who is definitely sick, and patients with septic shock should receive norepinephrine as the first-line vasopressor if they are deemed to not be fluid responsive by whatever measure you use. Again, passive leg raise being a very important one that can be used. Of note, you should always assess patients for volume responsiveness or fluid responsiveness, but it's not one of the answers in this question stem. And you should interpret CVP or central venous pressure with caution. The literature goes back and forth about how useful it is and kind of in what patient populations. So just always kind of take it with a grain of salt. Number 15, which of the following is the most appropriate next step in management? So really long question stem that basically gets down to a sick patient with symptomatic hyponatremia, which is definitely an emergency. When you have these patients who are symptomatic, you need to act quickly. You need to be able to give them hypertonic saline. So the correct answer is B, Bravo, the hypertonic saline for rapid early correction. And then your goal, since her last sodium was 110, is to get her, they say, up to 118 in 24 hours. Generally, the recommendation, it kind of keeps moving down. It used to be 10 to 12 in 18 hours, moved down to 6 to 8. So grain of salt, but you'll learn more about this in the electrolyte disorders lecture. All right, almost there, team. Number 16, which of the following is the most appropriate next intervention? So this is a 38-year-old who fell from a burning bedroom. He's got a positive FAST. His voice is hoarse. He's got carbonaceous sputum, and he has burns on his face. So ultimately, this is a trauma patient with burns. One of the things that you'll learn in that lecture is about the importance of intubating these patients sooner rather than later, because they're at high risk for developing swelling in the vocal folds and of their subglottic space. So the correct answer is A, endotracheal intubation with inline stabilization for cervical spine protection. And then he's also at risk for carbon monoxide poisoning, so he needs 100% oxygen. So very important concept, albeit he didn't look that sick by his SpO2, and he was otherwise somewhat stable. These are patients that you take their away pretty quickly. All right, number 17. Which EKG finding is the most significant indicator for immediate reperfusion in this patient? So B, ST segment elevation. It's a patient with a STEMI. They require that revascularization via cardiac cath to help restore that blood flow to the cardiac muscle that involved the coronary artery, and to help limit that infarction size and subsequent risk for post-MI complications. All right, number 18, we've got which is the most important strategy in this patient's management. So 45-year-old who is sick with a likely diagnosis of necrotizing fasciitis, which is a skin and soft tissue infection. Specifically, this is going to be Fournier's gangrene. This is generally a kind of a polymicrobial infection. The diagnosis and the treatment involve that immediate surgical debridement. However, it's very important to have empiric broad-spectrum antibiotics that include clindamycin for its antitoxin effects. So the correct answer is going to be B, Bravo, urgent surgical consultation plus the broad-spectrum antibiotics. All right, 19, which of the following is the best medication to add to his regimen until more definitive endoscopy can be performed? So it's a 75-year-old alcoholic cirrhosis, upper GI bleed, known esophageal varices. So somatostatin and octreotide, most of us are more familiar with octreotide, which is a somatostatin analog. So these medications indirectly decrease the splanchnic blood flow and therefore decrease the portal inflow, which is this is an important part of that standard medical therapy for patients who develop acute GI bleed from esophageal varices. I do want to highlight that patients with varices who are bleeding should definitely cause pucker factor for you all, because these are very sick patients who can decompensate very quickly and have a very high mortality from these varices, from bleeding varices. Number 20, which of the following would not be an expected laboratory finding associated with preeclampsia? So correct answer is C, Charlie, decreased fibrinogen level. So critical care in pregnancy is a very important topic. You'll review preeclampsia and many other critical care conditions in pregnant patients with one of our esteemed OBGYNs in one of the lectures. So without further ado then, that is the end of the pre-test review. So somehow I was able to keep this at a 30-minute lecture. I appreciate you all being patient with this first lecture. And again, I hope that you all enjoy the course. I will be giving a few of the lectures throughout. Again, if you ever have any questions, feel free to email me directly, John Hunninghonke. Just look me up on Outlook. Or feel free to email me directly at my personal email. I guess if you all don't have access to military email yet, it's John, John, Hunning, HAKE @gmail.com. I will do my best to respond in a timely manner, albeit it might be delayed by a few days as best as possible. But I definitely want to make this course as valuable as possible for you all. Again, knowing the limitations of doing it virtually, but I promise that we will give you as best an experience as we can. Thank you all very much.